Welcome back to the Atlas of Chiropractic podcast. I'm here with my co-host, Dr. Cameron Bearder, and we're joined by Dr. John Pitts from the Centeno-Schultz Clinic, just up the road from me here in Broomfield, Colorado. And we're going to talk about some really interesting procedures related to regenerative medicine, obviously adjacent to upper cervical practice and some of the types of folks that we treat. But there's a lot to gain from a conversation about the current state of regenerative medicine, the offerings that are available, the types of patients that we see that may benefit from these procedures, and so on. So Dr. Pitts, I'd like for you to at least just give us a little bit of background. How did you get into this space? Because surely when you went through medical school, this wasn't something that was like a path to practice.
Yeah, absolutely. So I was unique in that I went to medical school knowing exactly the field of medicine I wanted to go into because I wasn't one of those doctors that wanted to be a doctor when they were 5. I never wanted to be a doctor. I was interested in health and nutrition. And so I wanted to do PT. And then in undergrad, I switched to medicine because I found out about physical medicine and rehabilitation. So it was a way to kind of combine all that. So PM&R basically diagnoses and treats patients with musculoskeletal problems, and also helps to rehab patients from injuries. So I got into that field. And still, even into that field, there's not much on regenerative medicine that you're going to learn even in residency. So this is already past medical school. I was just fortunate enough training at Emory. There was a Dr. Ken Mountner who was starting to do PRP. He had a lot of diagnostic ultrasound skills and interventional injection skills with ultrasound with PRP. So I found out about it there and quickly realized that was where the future of medicine was going to go. Because prior to knowing about PRP and other orthobiologics, all we had to do for patients was steroid injections, pain management. If we sent them to physical therapy and it getting better, either they're stuck or we send them for unnecessary surgeries or they just have nothing to do. So I was fortunate enough just to find out about the Centeno-Schultz Clinic through him, and that they had a fellowship program. The only place had a fellowship that was offering specifically for this type of medicine, 100% solely focused. So I came out to Colorado and did that. And so I just kind of got lucky. And so working with Dr. Centeno and Dr. Schultz, kind of the gurus who started most of this work, is how I trained and came upon this field. And then Dr. Centeno had been working with CCI, Craniocervical Instability patients. So especially during the pandemic, we were getting a flood of those patients coming into the office. So we all began seeing a lot of those patients. And of course, Dr. Centeno-Schultz saw the most of them, but we saw quite a bit of them. So we got very familiar with that problem as well.
Well, the facility that you guys have up there, I think a lot of folks might not realize the tools that you guys have available. When I was up to observe and just take a tour of the facility, I mean, you guys got a full lab, you've got a researcher on staff, you've got interns and fellows and physical therapists there. You got a lot going on. So describe the clinical setting there and what you guys offer beyond the upper cervical injections.
Yeah, it's a very unique place in that it's a private practice with a very kind of academic focus and field. Again, Dr. Centeno had the foresight back in 2005 when we first did culture expanded injections into a disc based off a study in rabbits that showed that can regenerate disc. I had the foresight that, hey, let's start a registry. Let's start research, and we created a whole lab. And so now on site, we have a lab just for processing biologics that are going back into patients for making PRP, platelet lysate, bone marrow concentrate, et cetera. And then we have a separate university-style research lab that's head up by a clinical researcher, PhD, a lab PhD, and then we have all the cell biologists there to help out with basic science research. You get all the fancy tools and equipment because we do research, and we started a overarching company, Regenerative, that does a lot of research so that we can train other doctors. And then, of course, we have our fellowship where we train doctors to either stay on with us or to go off and participate in other parts of the country and starting their own and working with another regenerative medicine type of practice. So very unique in that you're not going to have a private practice with a full university-style lab or the kind of CMGP clean room lab that's just used for processing biologics. So we can make sure we have the higher standards and cleanest environment to provide these treatments.
Excellent. Yeah. And so you guys also have a clinic in the Cayman Islands, correct? Is that equipped similarly?
Yes. So we go down to Grand Cayman to do culture expanded stem cell treatment. When we first started, that's what we were doing here in the U.S. And then a few years in, the FDA said, that's like making a drug. We're going to classify that as drugs instead of the practice of medicine. We sued them, lost, and so weren't able to do that here in the U.S. anymore unless you run, hundreds of $1 million worth of drug trials, which no small clinic can afford and no drug company is going to do because it doesn't make them any money because it's not a drug. So we licensed that technology down in Grand Cayman. So we work with a partner down there that has a clinic just like any other kind of medical clinic, but then now they have the largest clean room laboratory in the whole Caribbean where they're processing all the cells. So they don't do a ton of research at that laboratory, but that's where all the cells are processed in the clean room, even bigger than ours here in Colorado.
That's interesting. Dr. Chris Williams, right? He just moved down there?
Yes. So Dr. Chris Williams is a good friend of mine. We trained at Emory together in PM&R. I convinced him to come out here to Colorado to do the fellowship. He worked with us for a little bit, opened up his own practice in Atlanta, was doing really well, and then just moved full-time for Grand Cayman. So now they have a full-time doctor to help treat local patients and patients from all over the world with that as well. And then myself and Dr. Marco here at the clinic still go down to Grand Cayman to treat some of our Centeno-Schultz clinic patients as well.
Dr. Williams is who I'm in Charlotte, North Carolina, and that's who I referred our patients to for posterior work.
Nice.
Amazing work. So I truly enjoyed, and I was extremely confident sending patients down to Atlanta.
Yeah.
So when I heard that he was moving to the Caymans, I'm like, oh man, this is, I told my patients, do you want to fly, take a vacation? Actually, quite a handful of folks were like, that wouldn't be the worst thing in the world. But awesome. I did want to ask, you doing the Orthobiologics fellowship, can you explain that and kind of break it down a little bit? Because I'm curious about what you did, how long it took, because chiropractors don't have a fellowship like in the traditional sense. I think that's something that we're missing. I'm curious to kind of know what you did.
Yeah, sure. So it's very similar kind of set up to other kind of academic fellowships, as we're not ACGME accredited or anything. And so typically PM&R doctors may go into, if they want to do outpatient medicine, go into a spine or pain fellowship. That's where they work with a doctor, basically doing mostly spine procedures. Some may be peripheral joints, mostly steroid injections, radiofrequency ablations. So they basically work with the tendon where they see patients, sign out to the tendon doctor so they can, make sure they have the right plan. And then they kind of tendon doctor oversees the fellow doing procedures. So our fellowship is similar, except for we just focus, all our treatments are focused on orthobiologics. So we treat the whole spine, we treat all the peripheral joints. And so we teach the fellows physical exam to kind of come to the right diagnosis, which is often overlooked. Most people just want to jump into procedures. Got to figure out how to diagnose and treat folks and get to the procedures. We teach them how to do all the procedures. So we got a lot of training videos. So they see us do procedures with patients. We overshadow them while they're doing procedures on our patients. And then, that's about 3 to 6 months. And then after that time, then they kind of on their own, seeing their own patients, starting their own clinic. And then if they have cases that are a little too complex for what they know already, they can kind of do those with us, older attendants as well. And then they usually also have a day of research where Dr. Centeno and the Regenerative team is giving them projects, clinical research projects to work on. So typically most fellows will get out 1 or 2 papers published that helps us with our research as well. They might do chart reviews or looking at imaging and kind of sorting patients or writing parts of the paper. So that's part of their training as well.
Wow. That's pretty. That seems like that could be done in at least in the upper cervical world, like having almost like an upper cervical fellowship, like almost kind of identical to what you just explained, especially if it was 3 to 6 months. When I hear fellowship, I think, oh, this is a 3-year process, which I'm sure some are, but it seems like, go ahead.
Our fellowship is 1 year.
Okay.
So a year long. And then after that, after 1 year fellowship, you don't know enough to be an expert. You know enough to keep learning. And so usually even after fellowship, and even now, I've been out 12 years, I'm still learning every single day. So you always have to have that continual learning mentality. But we at least are in the fellowship where they're under supervised quite a bit that first year.
Wow. That's awesome.
And is that Dr. Yale and Dr. Money there that are fellows right now, or who's training on your team as a fellow?
Dr. Andrew Pale and Dr. Melanie Worley are our 2 fellows this year. Yep, Dr. Money's finished fellowship, and he's been practicing maybe 3 or 4 years now.
Right on. Okay. Well, I was really encouraged by how welcoming your staff was and the docs there too. So let's talk back to, you mentioned getting to the procedures and the physical exam and the diagnostic workup related to that. I think that's really important. let's talk through that. So when you're assessing a patient for, let's say, CCI, and they may have come to you from the information that you have online, they may have come to you by referral from a provider. What is the due diligence process for qualifying folks for these procedures diagnostically?
Yeah, absolutely. So first thing is history. Okay. Do they have a story that sounds like CCI? So
Right.
most typically, you're going to find patients that have had some recent or even remote trauma, whiplash type injury, car accident, fall, hitting the head, concussion type thing, etc. So kind of mechanism of action doesn't make sense. Some folks with EDS or hypermobility or some kind of genetic issue where they don't make good collagen, sometimes they can have this issue without having a trauma. So that's kind of one step in the history. And then just kind of assessing some of the symptoms of the sound, like they have a lot of headaches, upper neck pain, maybe some autonomic systems, POTS, tachycardia, lightheadedness, dizziness, etc. So looking for all the symptoms that are associated with that. And then on physical exam, does the exam kind of hone in on the neck? So when you move their neck, does that reproduce some of the symptoms? When you palpate the upper facet joints, does that cause some of their pain? Can you do a Tenel's testing over some of the nerves and see if that reproduces a pain? Can we do some cervical instability or proprioceptive testing to see if those things are off? So putting that together is important. And then we want to have objective measures of instability. So that typically is some movement-based imaging. So the best way we can come to the diagnosis of CCI objectively is with a digital motion X-ray. And so with that, we're looking for ADI inflection, so to speak, which varies by age. In younger folks, more than 2.5 millimeters is kind of abnormal. As you get up into your 70s, more than 1 millimeter is abnormal because things shouldn't be moving as much because they usually have more arthritis. We're looking for a C1-2 lateral overhang. So if we get into more than 3 to 4 millimeters overhang on each side, and we have some asymmetry of the dens, that's pretty positively predictive for having a symptomatic craniocervical instability. We can also look and see if the C2-3 area has some abnormal flexion or extension translation, more than a millimeter, based on some of the studies suggestive instability there, and that ALL or PLL ligament is C2-3. We can kind of consider that the lowest level of CCI.
Mm-hmm. And so for students, if you're listening along and you're trying to think about, okay, what are the relevant structures here? Remember, for the upper cervical spine, it's a ligamentously stabilized region of the spine, right? The joints don't interlock as much. And so you've got alar ligaments with that lateral translational instability. We're thinking about alars, right? Those check ligaments. Inflection extension there with the transverse. You understand that that's where the ADI comes into play. If you see an increasing ADI, that's a big deal. But these lateral overhangs, I've even seen different measurements in different sources. I'm glad to hear that you at least have a reference range of about 4 millimeters, but we've seen them even bigger than that on some folks, and it can be pretty scary when you observe something like that on a DMX, especially in a patient that's been getting adjusted. So good. So think through that anatomy, right? And then you've obviously got joint capsules. Joint capsules are innervated. You've got, the actual facets. You've got the C1, C2 capsules, right? You've got the ALL, PLLs. You've got the tectorial membrane. You've got your myodural bridge. And, there's a lot going on there. So review the anatomy of the craniocervical junction three-dimensionally, right? And make sure that you're sort of thinking through all these structures with patients when you're talking about mechanisms of injury, right? Hyperflexion, hyperextension, lateral impacts, right? They could affect these tissues differently. It may present differently. So on the imaging side of it, our friends at Upright MRI of Colorado, they're very gracious, easy to work with. I mean, how often are you sending for the MRI? And if you do, how do you weigh that in light of a DMX?
That's a good question. So yeah, stop the DMX. So DMX most likely way to come to diagnosis. Second most likely would be kind of upright MRI, inflection and extension. So there you're kind of looking more for if we're having some excess movement in the atlas and the occiput when you're going into flexion and extension. So measurements like BDI and grab oaks can be used. The change in grab oaks from those can be used for that type of instability. Having a very low clivo-axial angle, less than 125, 30 degrees can be used. And then you can also look and see if there's any damage to the spinal cord, especially with flexion, or if you're getting a little signal in the spinal cord. So you get cervical medullary syndrome. So those are the kind of things we're looking for in the upright MRIs, mostly flexion, extension at those upper levels.
Doc, your thoughts on fatty infiltration and how you of the C2, C3 or C1 through C3 area, is that something that you've seen a lot with your CCI or AAI patients?
So you mean like multifidus and suboccipital
Yep.
muscle atrophy? Okay, yeah. So yeah, we often see that for certain, because some of these patients may have been told, hey, you need to wear a neck collar all the time. And so you get significant amount of atrophy. These patients don't like to move. So, I mean, literally, if you see some CCI patients, like they will turn their body, they won't turn their head. And so you get atrophy of the muscles because they're so scared of movement because it flares them up so much, they can get a lot of atrophy there. So, that's very common to get that. You get that also just lower cervical and other spinal problems as well.
Do you see, just kind of a broad question, would you correlate a higher amount of fatty infiltration and atrophy with an increase in symptoms or a greater perceived magnitude in craniocervical symptoms?
That is a good question. I don't know if we have enough data to say that with any certainty. Certainly there's evidence when you have that in the lower lumbar spine that, hey, the more multifidus atrophy you have, the greater probability you have of symptoms. I think for CCI, the biggest things are, maybe just the degree of instability. So how large are those numbers on DMX with overhang or ADI, et cetera. If they're having any, issues where the spinal cord is getting impinged, with cervical medullary syndrome is a big one. And then how long have they had the problem for? And it kind of relates. So probably the longer they've had it, the more inactive they've been, the more multifidus atrophy and fatty infiltration they have. So it's probably a correlation there. But we haven't really kind of pieced that together to say that with any research behind it.
Is there anything that you would recommend there's a device, I know Iron Neck is kind of a nightmare for this type of stuff, but Next Level has been a really interesting device that I've used for fine motor of the intrinsics. I'm curious if there's not a physical therapy, but almost like a rehab program, obviously not using tremendous weight, 1 pound, a little bit of band resistance. Is there something that you have found, in your years doing this that has been largely beneficial in addition to the procedures?
The key thing with CCI patients is that even though, look, they might have loss of neck curve and significant straightening of the neck and kyphosis, they might have severe atrophy. But some of these patients, they can't tolerate literally being upright.
Yeah.
So some of these folks, they can't do any physical therapy. They can't do any exercises. They can't do any Next Level, Iron Neck, anything. So in that population, we have to get them a little better first with procedures and some upper cervical chiropractic adjustments first before they can do anything. For folks that make it through that, or for folks that aren't as severe and they can tolerate some things, we've developed some laser exercises where we kind of basically have a clock and give them a laser to point and just do some gentle little neck movements, moving the eyes. So just kind of getting some activity in that neck. That's very gentle and helpful. So less is more for these folks. I think Next Level, we just started working with that a little bit. I think if you use it the right way and don't go too aggressive, that's a very gentle way to kind of get those muscles moving as well. We've also worked with some, physical therapists that specialize in upper cervical rehab. And so just kind of training them, hey, again, less is more. Don't be too aggressive. Just basic postural exercises, just basic eye movement type exercises is very helpful for this group. Now, sometimes you have a high functioning CCI person, and heck, they can even tolerate something like an Iron Neck. So it's very patient specific, but the majority of folks we see, can't start physical therapy until we get them a little bit more stable or their alignment's a little bit improved.
That's
You got to figure they're so centrally sensitized by the time they're that far down the road that just meaningful small inputs that can accumulate some capacity metabolically, if for no other reason, in the muscles, but then obviously to the tissue tolerance. I mean, that is a process, and I think a lot of these folks understand that you're going to need to be consistent with thoughtful strategies over a long period of time to build that capacity back up. And any amount of time that you've been unstable is a tremendous insult to the body. So it's going to be something that needs to be worked out thoughtfully.
Yes.
Are you guys also using Neck Care as Diagnostic? Is it the headset that measures joint position error?
Yeah, we just started using that one as well. I haven't used it on any of my patients just yet. Dr. Centeno is kind of running through his patients to see if he likes it and if it provides some good information. So we just started using that. We have it in our room. So we'll probably figure out if we like it and how much information we think that's helpful here in the next couple months.
cool.
Very cool. Yeah, both of us have been using it in practice for a little over a year. And it's
Nice.
really interesting to correlate with, at least on static CBCT images, and Cameron does end range scans, but it's interesting to look at the movement parameters next to the imaging and see when things match and when they don't. So I'd be curious to see what Dr. Opinion of that information is and how it enhances your understanding or not. But it's a
Yeah,
really cool
absolutely.
company. We appreciate Netcare. They do a lot to support the upper cervical community, and they're really trying hard to help quantify some of these things that, we're talking about proprioceptive rehabilitation and even just diagnosis with that. Just having an actionable, accurate, user-friendly way to capture that data is really important. So I appreciate what they offer with that.
And it should be helpful for maybe post procedures and post interventions to see if you made some objective progress. Because as a
Correct.
person living in your body every day, you're in tune with every little thing, but sometimes you don't notice those subtle things until they bigger changes.
Yeah.
Yeah. Yeah. Well, I'd like to talk through a case with you maybe. And when I was up to visit, we, just to jog your memory, we had a patient in there who came in for Hawaii for her second set of procedures. She had PCL. You did some posterior work. You did some thoracic work, some SI. It was kind of an extensive process. How aggressive can you be with these procedures, and how often are you incorporating multiple regions or sites or products with these folks?
Yeah, good question. So if we identify that patient is kind of what we call like the fragile egg or they're centrally sensitized, again, less is more. So for those patients, we're typically just doing the PICL, and then we may or may not add a little just PRP to some upper facets and the posterior ligaments. So that's typically maybe like the minimum on the baseline that we would do. Now, if we feel like a patient can tolerate a little bit more, maybe they've had some procedures and we know they handled it well, or just based on exam and their previous experience with other interventions, they haven't got extremely flared up, then we can add in other things that are related. So, I mean, if you got CCI, you're going to have some lower neck issues, I'm sure. Sometimes you have nerves that are irritated, that might be secondary, but still cause enough problem that we might need to do some hydrodissections. When your neck is affected, you're going to have some AC or sternoclavicular instability, maybe some shoulder instability that can be helped out with some PRP or Prolo. If you got neck issues, you got low back, SI issues. We see all these different problems. Just depends on if we think that patient's centrally sensitized, how their response to previous interventions have been, as to how much we can do with that group. We try not to be overly aggressive, but in some folks that tolerate procedures really well, we can get a lot done in one trip. Saves them time and cost and gets all the issues taken care of, so they got a better chance of better long-term success.
Well, I gotta say, I can appreciate how it may take several procedures to really get this, tissue glued together, as some upper cervical chiropractors like to say. Obviously, I was impressed at the image guided nature of it. Like you're literally moving the needle a little bit, and you're looking, in opposing views, and you're trying to find that tissue. But at the same time, like, it is a living body that needs to take up that tissue and have it differentiate and work to do what you intend for it to do. So I can appreciate where, you gotta, and this would be for the chiropractors who may be counseling folks on pursuing something like this. So let them know that this may take a few rounds. Like, we've got, some work to do to enhance the tissue here. And so one thing I was taken by through the process, we even saw a little bit of that leak into the C1, C2 capsule incidentally, right? And so when you're putting this product into living tissue that's circulating, I mean, there's a lot that needs to go right for this to be a one and done type of thing. And I'm sure that's less often the case. And there are those situations where it does happen. But again, there's such a severity, such a spectrum of involvement with this kind of thing that you really got to do your best with it, and then just see how the patient tolerates and work it out.
Yeah, the most influential factor is the time since the injury. So if we can catch you early within the first year of an injury, you can be a one and done, and you can get back to living your life as if nothing happened or close to it. But how often are we seeing that? Because they don't get to us first. They might work with somebody, and they've even if they got a great chiropractor, they don't know about us, and they're like, man, I want to send them to a surgeon or a pain management. That's all they're going to do is get steroids. What do I do? We might not see them for a few years later, or they get caught up in the Western medical system. And, oh, you're crazy. You don't have a hangman's fracture, so there's no such thing as instability. That's not a major fracture. You're crazy. So they've seen 20, 30 doctors over the years. Nobody's diagnosed them, so they don't get to us. The biggest problem is that, hey, they need to know about us and this treatment, that if we catch them early, it can be a one and done. but most of the folks we're seeing years out. And so for most of those folks, based on our research, 2 to 4 treatments typically get some kind of max improvement or get some where they need to be. And it shouldn't be, hey, you don't get better until after 2 to 4 treatments.
Right.
Majority of folks are getting better after one, but then they continue to improve each subsequently. And then there's some percentage of folks that maybe don't get better after one. Half of those will get better after a second procedure. So we might give it 1 to 2 procedures before you say, hey, this was a failure, before say, okay, maybe you're too far gone and need surgery.
Well, yeah, it's as time goes on and more of this information gets out there, hopefully we cut the time down between when folks have an injury and find these options available to them. Because, man, and I tell patients this all the time, and it's true with chiropractic, any profession. When you're in the middle of a health crisis, and you're hoping that you happen to get in front of someone who's up to date with the latest in that moment of need, it's not the odds are not in your favor there. So you've got to unfortunately go to the deep dark recesses of the internet to try to find information. I really appreciate the ebook that Dr. Centeno put together, because it's a really nice primer on CCI for folks in terms of, okay, what diagnostic procedures do I need to have? What's the criteria for thinking about? It's not just the symptoms, that'll get you started, but there's a process to selecting into these treatments and making sure that you're going to have a successful outcome.
Absolutely.
It's been interesting to kind of see everything unfold over the last 5 years. I think it's really interesting. I want to ask the question about, you mentioned an increase of all of this during COVID, but John and I have talked about this at various times on this podcast and kind of privately offline, as it were. And, the CCI Facebook groups are unbelievable. And that's not a compliment. And it's more of folks who have been seen, 4 different doctors, chiropractors, PTs, and I mean, everyone. And it's been 5 years and they finally get the diagnosis. And a lot of these people will put their imaging up. It's almost like a master's class on like what not to do.
Any opinions on this image? I'm like, oh my God.
Yeah. And that's a whole nother, that's a 5-hour long conversation, but I have to wonder, what is the algorithm not doing? Because I feel like if someone types in CCI, Centeno-Schultz Clinic's probably going to come up first, how are these people not getting directed to the appropriate source first or second, but they're having to go, they're having to travel to people all over the country to kind of get not even really a shoddy diagnosis. It's been heartbreaking to see it over the years, and it's getting worse. So that when you said the comment about like things got worse over COVID, that really kind of resonated with me. Can you expand on that?
Yeah, I mean, I think humans like stories and they like connection to feel like they're connected with other folks. So Facebook and the social media can be a great place to get that, but it comes with a ton of risk and negatives, right?
Yes.
So us in the medical profession, if you told me a patient's story of a success, I'm like, yeah, okay, but I'm not going to make it that's any credible thing. You got to show me some published data, a series of patients. You got to prove to me the mechanism. But for folks on these groups, they just hear a story and, oh, bam, it sounds something like mine. This person had success with this. I'm going to do that. Not understanding every patient's different. Every diagnosis is different. And there's a lot of just kind of junk and nonsense out there. And so how to kind of search for credible information is really hard. So, for patients out there, they need to look and say, okay, any other intervention that they have, somebody should be producing some type of data or evidence, a mechanism as to how this happens. Shouldn't just be patient testimonials alone. It should be some evidence based to it. Kind of try to dig in and ask some questions like, okay, is everybody a candidate, or people are not candidates for this type of treatment? You have to dig and ask questions. And it can be difficult for a patient with no medical background to kind of sort through this. Whereas for someone like us, if we see some scam treatment going on, we can easily sniff that out because we know the right questions to ask and the things to look for. So yeah, it can be really good to find people that, hey, they share similar diagnoses and problems, and I know I'm not alone, and maybe talk about their experiences. But when it gets to you taking medical advice from people you don't know online and just trying to trust in non-professionals, then you get into problems.
Well, even the professionals, I'd imagine you guys do encounter resistance from folks in your space that don't know about what's going on. I had a conversation with a neuro rad locally when I was there asking him some questions about some imaging. And I brought up to him, are you familiar with these regenerative medicine procedures? We were talking about CCI. And he goes, no, but that doesn't sound like anything I would be very skeptical of anything related to that. And I thought, that's very interesting. Like, he obviously is not aware. And it's a new procedure, right? This is something that is in development, and you guys are doing research, but I'd imagine there are folks in, let's say, orthopedics or neurology or, PMR that are unfamiliar or maybe uncomfortable with. They may have had patients that brought this as a potential solution to them and had it sort of kiboshed. So what's been the response in your community to these types of procedures? And is it being embraced? Are you having some difficulty with bridging the gap there? Or what's been the intel from your
I
side?
think is two issues broadly. Of course, probably many, but one is just that there's not a lack of education in the medical training period for craniocervical instability, one, and for regenerative medicine. I only happened to find a doctor who was doing that in my residency. That's the only way I knew about it, doing any type of training. And then with CCI, I just happened to be at the place where we were doing it. So it was just by luck that I know any of this stuff, right? So it's a lack of medical training there. So we're taught kind of black and white. Hey, you have a hangman's fracture, your neck's falling off, you had a spinal cord injury, you need surgery or not. People don't understand ligaments can be partially torn, damaged, loose, injured, causing a myriad of symptoms that don't necessarily need surgery or not life-threatening imminently, but still are a problem that's not going to heal up on their own. And then secondly, regenerative medicine, since there is no formal training in it, you're relying on, which doctor took the most time to learn this on their own. Again, we're the only place to offer a fellowship in it. Any other doctor's really good has just kind of self-taught themselves or learned at conferences or has done some research themselves. And then everybody else that's doing this is just kind of learning from those people, from conferences, weekend courses, reading papers, etc. So it's going to be a wide range of experience and expertise in this field. And then you got a big chunk of that is just scam folks. There is a lot of scam treatment in regenerative medicine. So I am just as skeptical sometimes as the folks that are skeptical of what we do, because you should have a healthy skepticism. But to say, oh, this has no evidence, there's no research, this is new, is just false. At this point, we've been doing this 20 years. The doctor in France has got published papers going back 30, 40 years. PRP at this point has more than 130 plus randomized controlled high-level studies showing it's helpful for a variety of problems. Bone marrow and stem cells each year gets more and more research data. Centeno posted just an update of all the stem cell research data that has come out over the years. So you can find it, but you have to really do your due diligence to kind of sniff out scams versus beginning doctors versus very experienced doctors versus the top experts. Mm-hmm. So for something like CCI, there's no other place that does PICL. So you might know doctors that know something about CCI and maybe some treatments for it, but they can't do PICL. But at least they know about it and can, kind of direct you as to what's going on. And typically the chiropractors have been leading this field because, chiropractors are doing the DMXs, the diagnose things. The upper cervical chiropractors are understanding this issue and doing the adjustments that can be very helpful and adjunctive to the things that we're doing, and sometimes help us not even need to intervene at all. So the medical establishment's got a ways to go, and it's more of an education thing, I think.
Yeah. Interesting. Now, there's a lot of, related symptoms that don't seem like neck problems, right? When you're getting into the dysautonomias and some of the jugular vein compression type of, symptoms and things, like, it can be pretty convoluted. It wouldn't always lead you to think about the neck. And so those of us that, deal with folks with these types of issues, and we kind of have an idea of the clinical phenotype of sort of that sort of thing and connect the dots between the mechanisms of injury and the tissues involved and the symptoms and the timelines and the things that are related in genetics and family history and all. It's a lot to put together. And I can appreciate where the average, doc with orthopedic training is just not connecting those dots. And it's not their fault, but, we need to do better because these folks are suffering. And obviously, to your point, the incidence is not going down, and so there's going to be plenty of opportunity in the future to enhance these things. But let's talk about the PICL specifically. And what goes on with that procedure, the target tissues, how you guys go about it, and how that might relate to patients that upper cervical chiropractors see.
Yeah, absolutely. So it's a very involved procedure for an injection, but it's still way safer than any kind of surgery you can do. So to pull this procedure off, you got to know the anatomy and the structures you want to inject. So the primary targets in the PICL procedure are going to be the alar and alar accessory ligaments, commonly the transverse ligament. We can also target the ALL, SAOL, apical ligament, tectoral membrane, all those things as well. You can target the anterior portion of the 0-1 facet capsules if you want to. So those are kind of the main targets through the PICL. So these are the ligaments you inject through the back of the throat because they're all anterior to the spinal cord. So it's no safe posterior approach for those ligaments. And then to do that, we have dual C-arms. So you saw one C-arm that's getting a lateral picture, one C-arm is getting an AP picture. So at any moment in time, we can take a picture in each direction and know exactly where our needle is in 3D space. So we're not veering off to medial, lateral, superior, inferior, etc. We've got to have a specialized 3D printed mouthpiece that the patient has so they can depress the tongue so we can get a good view of the posterior oropharynx. And since we're in the back of the throat, you have to have a light. So we have a laryngoscope so that we can see that posterior oropharynx so we know where to place our needle. All that has to be sterilized as well. We give them solutions to sterilize the back of the throat and the oropharynx area for cleaning that off. And then we got to guide that under direct X-ray image guidance to the target. But just knowing what a target is, just on the picture alone isn't enough. We need to inject a little bit of contrast so we know that, hey, our contrast is flowing along our directed target. Because sometimes people have different anatomies that may be a little bit off. Sometimes they have tears in their tissue, so the injectate leaks out and you have to redirect to make sure you get it to stay exactly where you want it. So you want to finalize all that. So all that goes into making this procedure a success.
And under general anesthesia, right? These folks aren't awake watching you do this.
Yeah, not general anesthesia, TIV anesthesia, which is total intravenous anesthesia. So we'll have a CRNA in the room. So first, Dr. Schultz, who's anesthesia trained, was doing all the anesthesia. So once he figured out what was kind of the best way to do anesthesia, he taught the CRNAs. And so now we have CRNAs there for the anesthesia, which is a tricky balance of keeping the patient breathing, number one importance, but then also we got to keep that patient still and comfortable. And sometimes that line is very thin, particularly if they've been taking a lot of narcotics, or if they've been using marijuana, or if they've been on low dose naltrexone. So we want to try to get them off of some of these things beforehand, because that dramatically increases the anesthesia needs and makes that thin line between breathing and comfortable to comfortable but not breathing, very small.
Doc, did you mention the C0, C1 joint? I could have sworn you had said something about C0, C1. What are your thoughts on that in terms of as a concomitant with CCI of C1, C2 overhang? Because having cone beam, and from an upper cervical standpoint, we can see a lot of disarticulation of C0, C1. And I've taken post adjustment cone beams, updated cone beams from CARE. And there really isn't a lot of movement there. So it makes me think that there's probably some sort of capsular damage or soft tissue damage. Did I hear you correctly that you could inject those?
Yeah, well, we typically will inject the C01 joint posteriorly.
Okay.
Because these patients have a lot of arthritis or pain in that joint because the neck is unstable, so you're going to let us stress in the 0-1 facet joint. The C1-2 facet joint is also going to be a common place to get arthritis or instability or pain in those joints, and the C2-3 joint as well. The three most upper joints and most common ones affected, but CCI. But I was just saying, during the PICL, if we wanted to, if a patient had a lot of extension-based instability and maybe you saw the 0-1 is disarticulating an extension, you can also treat the anterior part of that capsule. Yes. So how important the facet capsules are is probably minimum, but adding a little bit of help there could be beneficial for certain. So the major ligaments do most of the stability of the neck, and the capsules play a smaller role, but they play a role.
And there's nociception there, right? So you can be contributing to the pain experience and some of the response to that. Yeah.
Interesting.
Cool. As you guys have evolved the procedures, what do you think is the most promising breakthrough in these injections with CCI? Do you think it's the recovery time? Do you think that it's the number of procedures? It's the symptomatic outcomes? What would you say has been the greatest leap forward as the procedures have advanced?
Basically advance the procedures is how can you make it safer, more efficient, and better targeted. So pretty much all advances in the procedure itself is related to that, where, hey, we can more easily, quickly target, the alar and all parts of the alar, accessory ligament, transverse, etc., so we can get the injectate exactly where it needs to be. And thus we would, then, hypothesize that, hey, we can get better results, either meaning more subjective improvement or less procedures needed, etc. So we're actually running some data now comparing what Dr. Centeno calls the E or enhanced PICL, where we kind of made a big leap in targeting the alar ligament more precisely compared to beforehand, to see if it's making some improvements in outcomes. So again, in a few months, we should probably have enough data to see if that's making a bigger jump as far as patients getting better quicker or more improvements.
And are we seeing are you doing DMXs down the road? How do you confirm that, okay, we've actually established some stability here?
Yeah, it's a good question. So with post-procedure testing, there's always a balance of the kind of risk-reward. These procedures, DMX is radiation, which is no safe amount of radiation. So we want to limit that when we can. And also they cost financially. So we only make a patient get a new DMX if maybe we've done a couple of procedures and we're unsure if we need another one, we're unsure if we're making some progress, and we want to check to say, hey, the DMX is getting better, we're on the right track, or hey, your DMX is actually normal now, maybe we don't need any more PICLs, it's more about rehab and joints. That's the only time we always make them get it. But also if patients are curious and they want to know, hey, I want to see if my DMX changed and get some objective data, and they're okay with the cost and a little extra radiation risk, then we'll get the DMX to show that as well. Majority of the time, after a couple PICLs, you will see changes that are significant on the DMX.
Yeah. Well, and I mean, if the patient's symptomatically doing well and functional in their life and they're making progress in the things that matter to them, I mean, you're not going to overemphasize the image in the case
Correct.
that their life is better, right? And that's where upper cervical chiropractors can also be an ally, because if you're seeing that folks are holding their adjustments longer, when we're correcting head neck positioning, they're maintaining those changes over a longer period of time. There's more neuromuscular control of head neck movements, less provocation of symptoms with things that shouldn't be provoking symptoms. I mean, you're stacking, accumulating some evidence that we're where we need to be. And
I tell patients that it's like if they've already had a good upper cervical chiropractor before seeing us, but maybe those adjustments are helping them for a day or 2 days or 3 days, and then they kind of have to keep getting them repeated. After we do PICL, then they go back to their upper cervical chiropractor. Then after some time, they're holding, for 5 days now, then 7 days, then 2 weeks, then a month. And then you know what? They're holding unless they did something a little too much and they went out and they just need an adjustment every now and then. So you'll see the need for adjustments or the holding of adjustments increase over time. And that's really a great sign. So we're very thankful for you guys to help out and with that as well.
Question for you. When were you introduced to upper cervical chiropractic, and what convinced you as a medical physician that it was beneficial for your patients? When, was there a moment? Was there something that you were like, oh yeah, this is this?
That's a good question. I don't have a good moment like that. Just when I started seeing more upper cervical patients, and I got the benefit of being taught by Dr. Centeno and Dr. Schultz, and so when I would see the patient, they say, hey, I've got a good Atlas orthogonal or orthospinology or nuclear chiropractor that helps my symptoms, then I'm a believer in what's helping the patient out. So I'm not biased by it was a chiropractor or an acupuncturist or a PT, whatever. Whoever's helping my patients out, I'm on board with. So then you meet with upper cervical chiropractors to kind of explain to you what they're doing and why, and give you some confidence that, hey, they know what they're doing and have some background and understanding. I send folks to upper cervical chiropractors all the time. So unlike some cases where, hey, oh yeah, they have the chiropractor, they send them to us and that's it. Like, we actively will tell the patients, if you haven't seen an upper cervical chiropractor, you should seek one out. I want to see how your response to that treatment is. I believe that in most cases, that's going to help you out. And then, maybe if you saw one and you didn't have great results, maybe try another one, because, expertise, just like in any field, can vary quite a bit. So yeah, we're a big believer in that. I know I've been working with you guys for many years. So it wasn't one aha moment, but we've been used to working with chiropractors since we've started, because chiropractors and us type of physicians tend to be more focused holistically. We're not afraid to be on the fringe if it's effective and it's making sense. So a lot of times in medicine, the stuff that's the standard of care is crazy. Like, oh, I'm just going to shoot people up with steroids. We know that they're dangerous. We know that they cause X, Y, Z, a million problems. We know they don't provide short-term benefit, and we don't even have good evidence to say that they even help in the short term compared to just a local anesthetic or placebo. But this is the standard of care. So
Yeah,
this
it makes
doesn't
you
make
wonder.
sense. So I always just follow what makes sense and what's helping patients rather than who's doing what or what's just, oh, that's just what we do.
Yeah.
Is there something that we could be doing better, in your opinion?
Oh, that's a good question. I think the biggest, I don't have an issue, but the biggest thing I would just say is, hey, if you're seeing a patient and you think they have CCI and you're working with them,
Mm-hmm.
if you're not making the kind of sustained progress that's getting them better over time in those first couple months, send them this way to see if we can help them out.
Okay.
Don't wait for long periods of time. Now, you don't have to just look at them and say, oh, I'm going to send them right away. Give it a fair shot because a lot of times you can save them from coming to see us at all. But yeah, just send them to us, early on instead of later.
Okay. Good to know.
And I guess as a comment to the listeners who may be younger in practice or students that are interested in upper cervical, the way you might think through that, obviously, like he said, the history is such an important interaction with the patient that will get you so much farther ahead of trying to figure this stuff out later, right? So I will put the link to the ebook or on CCI there for you folks to look at, so you can get an understanding of like what are the radiographic measurements, what are the symptoms, what things what things would raise my red flags to potential CCI. And then when you take your images, you may say like, if we're taking x-rays, like let's try these lateral bending APOMs and let's just see if we can get a look at it. Is there any evidence of some gross instability there? If you're doing CBCT, same thing. You can be measuring ADI spaces and periodontoid spaces. You can be looking at the articulations and does this make sense with a misalignment type of pattern, or are we seeing something that doesn't match what we're used to, right? And are we provoking symptoms by putting the head neck in these positions like you were saying? And the patient may tell you that, in the case of taking your history. So these are ways that you might start to make a mental or physical note that, okay, potential CCI. Do your Baton scores and all that kind of stuff. Look for general or acquired hypermobility. Look for family history of things that might lead you along the lines of that collagen, not being as healthy. And there is such opportunity if you are able to, catch this stuff early, to Dr. Pitts's point, and get an idea of like, okay, we're going to take the next 4 to 6 weeks and like very closely monitor how you do with that first adjustment or two. Can we get any holding there? Can we get a positive response? Are we very confident that the movement and positioning of the upper cervical spine is related to your symptom profile? If that's the case, great. We know we're adjusting you right. We've checked our technique parameters, but it is just not staying. That's when you're going to start to think along those lines. And I would encourage folks to, give it 6 to 8 weeks and then start getting a little bit uncomfortable with, man, if we're doing everything right and we're really not breaking through, let's start the conversation, right? Because it's going to take time to get to the treatment. And obviously time is of the essence, for recovery purposes.
Yeah,
So
just think about all the factors that go into helping a patient with instability, right? So a lot of times what you're focused on is kind of alignment, posture, positioning, right? Some other chiropractic techniques might be helping with curve restoration, again, alignment, posture. I think, hey, to help maintain that alignment and posture, you need muscles. So that's where exercise type therapy comes into play. And then also for the end ranges to prevent excessive movement at the end ranges, that's ligament stability. So, there's no amount of exercise or chiropractic adjustments that are going to fix ligaments. That's where you need interventions. I'm not going to fix your alignment by injecting you. All right. I'm not going to activate your muscles to get stronger just by injecting you. I can help the nerves that go to them. So then you can do that, but then you need help. So this is a team aspect. This is a team approach. So we each are coming at this problem from different aspects and all work synergistically.
Yeah. Beautiful.
There's been something I've been paying attention to over the past couple months. It's been interesting. I've been taking lateral flexion cone beam at end range, and you can literally slice through. So like on DMX, you've got the jaw issues and patient positioning potentially. So obviously this isn't motion, but something that I've been seeing more and more of is if there is a little bit more excessive movement of C1, C2, I will start to look at the uncinnates or the joints of Luschka, at C2, C3, and go a little bit further. Arthritic change or some sort of deformity or malformation blocking and restricting that lateral flexion. I've been starting to wonder, is this almost a secondary type laxity because of the arthritic change? Right? So like almost like an acquired CCI or AAI and it's more in like severely degenerated patients, but they're facets. So like the facet joints on the posterior side actually look really good, right? And so in theory, they'd be able to glide well in rotation and lateral flexion. But when I go and I look and I see that, the uncinnates are almost obliterated or arthritic, I'm starting to think like, I wonder if cone beam can allow us a clearer picture, a more obviously 3D picture to potentially not classify, but better understand the mechanics of the cervical spine, the craniocervical junction, and better understand the patient's history of, do we need to do a particular type of intervention, almost like an algorithmic, like, okay, do they need this because they have arthritic change at those joints? Or if those are clear and they have that lateral overhang, like that is an obvious alar issue. You know what I'm trying to say?
Yeah, so it's helpful to just kind of understand, hey, when you're seeing any kind of bone spur, osteophyte, or the arthritic changes where there's hypertrophy of the bone, all of that is telling you that that area is unstable and it's getting extra stress on it. So any area that gets more stress on it, just like you get stress on your hands, you get a callus, your bone makes callus to actually improve your stability. Right? So any area that has an excess of bone is unstable, and that's your body's compensatory mechanism to try to make it more stable. So sometimes you might get into situations where the bone has gotten so big that actually causes some restriction in movement. So that might artificially make you think they're not unstable. They have restriction instead of hypermobility, but they just overcompensated because they got too much of a bone spur. So those to keep in mind. So there's no such thing as anybody's ever had any arthritis and they weren't unstable. If it could just be alignment issue, PT chiropractic might help. If it was just a neuromuscular issue imbalance, PT chiropractic can help. When it's a ligamentous issue and PT chiro has tried and it's not helping, then that's where you have to treat the ligaments for the stability aspect of any joint that's arthritic.
I like it.
Well, you need to help folks make sense of these findings that you're relaying to them, because if you look at a lateral and you're seeing, severe degeneration at C4, C5, C5, C6, the rest of the discs look okay. That's not aging, right? This is not just natural degenerative changes. This is an injured site. And I tell folks all the time, one of these things is not like the other. You tell me if you think that's right, and if your doctor said, well, that's age related, ask them, at what age does my C5 disc break down, right? Like, it doesn't make sense, to your point earlier. And so if you have the mechanism of injury, say, you had that gnarly whiplash 15 years ago, you probably became unstable down there. Your body did what it knew to do to lock that down and to prevent that further insult. But now it's maybe hypomobile. And so now your upper cervical spine has had to compensate, and put those ligaments under strain more consistently in those end ranges and approaching those end ranges. I mean, it starts to build a case for, why you're in the shape that you're in. And so then we may say, okay, we know you have that, that restriction there. Is there something we can do with posture, with alignment, to create more optimal conditions below the area where you're going to go and intervene, so that we can reduce some of the strain on those tissues while they're healing, to make your procedures more efficacious? I mean, those are the ways that upper cervical chiropractors can think through and try to set folks up for a good outcome if they do need to go and have some of these procedures done. Because by the time you're looking at the neck, you're, like you said earlier, then the shoulders come into play, and the TMJ comes into play, and the oculomotor system and the vestibular system, right? It can get pretty deep pretty quick.
Absolutely.
But I think we've given folks some good context for thinking through, when this might come up, how you might broach the conversation with patients. And then we'll obviously put the links in the show notes here for the website. Dr. Centeno does a good job of going live on Facebook all the time and has conversations about a lot of this stuff.
LinkedIn. He's ripping on LinkedIn. It's crazy. Every day.
He doesn't sleep, and he works 25/8, I'm pretty certain.
Jeez.
As long as he's not expecting that from his fellows,
He does.
Yeah, rightfully so. But listen, we appreciate the generosity of your time and sharing with our community. And I know that you folks are always welcome to upper cervical chiropractors observing and finding ways to help make connections into our community. So follow along with what those folks are doing up at Centeno-Schultz. And if you have patients, that need to come out for procedure, come with them. If it's at all feasible, come along with your patient and observe them go through these procedures, and make sure that you know, if it's possible, be a part of the conversation, so that, like you said, that collaborative, synergistic approach can play out. Because man, it takes a team effort for these folks, and a lot of them are suffering horribly and need all hands on deck. So appreciate you guys being collaborative in your approach, and being amenable and open to upper cervical chiropractors. And we appreciate what you're doing.
Yeah, you guys are essential to what we do. We always refer to you guys. We've had, we see people from all over the world and all over the country. So I've had several patients that have had their chiropractor on the televisit with them. I've had a chiropractor watch the entire PICL for their friend and patient. So yeah, we're very open to that. We want to spread the word. We want to learn and collaborate. The more you guys know about us, and the more we know about you, and the more we can get the word out to other providers, doctors, MDs, chiropractors, physical therapists, etc., the more resources this patient population is going to have, so they can actually get the help they need sooner and not go down these rabbit holes. Because when you're desperate and you don't know what's going on, you're gonna fall into a lot of scams and traps.
Absolutely.
And we see it all the time, unfortunately.
Yeah, absolutely.
Yep. Good deal. Any last words of encouragement for young budding chiropractors, or maybe even physicians, if they were to come across this and they get interested in this idea? Any words of encouragement for pursuing in this field?
Just learn to think outside the box. Don't take what you've learned in school, residency, professors as gospel. We all have a ton to learn. And so the deeper I've gotten into this, the more I think I don't know. So I feel like more of an idiot now than I did 12 years ago, because now I know all the things that I didn't even know were possible that I should know.
Yep.
So always be willing to learn and think, and don't be scared to go against the grain when you know it makes sense and you're seeing folks get better.